Good afternoon from ESHRE 2023 at Copenhagen, Denmark, and good evening India, and it's pleasure to be on Mankind Platform So Open. Today we are with Prof.Herman and we are going to discuss innovative in advances in infertility management. Professor Herman is from Basel. He is in charge of Andrology Training Center of European Academy of Andrology. He has received his degree of MD in 1986 and sir had pursued my MBBS in 1986. There are so many similarities in your CV. Sir has got special interest since his journey in medicine. He has done his thesis on cryopreservation of oocytes and embryo. Sir has done PhD in 1994 and I will pursue my PhD in 2025. In 2000, sir has started BITE. Don't get confused, it is BITE means biology of testes, and it's a special interest group. Till 2012, sir has got so many publications, out of 47 as a first author and 40 as a second author, and I got 87 as ORCID publications, sir. And he is board member of SIGA in ESHRE and has served past so many prestigious posts pan-Europe. So sir, you are being expert in the field of infertility and having vast experience in so many years. We will take advantage of their skill and the knowledge of our infertility specialist. Sir, you know nowadays everybody is talking about GnRH antagonist cycle. Okay, so the protocol which we are using conventionally in early follicular phase, and some people are saying that you have to use in late follicular phase. What is your take on it? Which is good for our patients?
Well, it depends a little bit, I think, on what you. It's mainly a decision taken by a clinician, and from the patient's viewpoint, I think that both approaches can work. Now, we did a study where we started, well, the conventional way or the late follicular phase, and basically there is not a lot of difference. So, in fact, both approaches can be used. The only thing is, of course, that the reason why you would take one or another may be costs involved. Because you can save on something if you don't use the GnRH antagonist all the time. It may also reason to schedule things, to avoid maybe some days. And that's maybe one of the reasons why we got an interest in doing that study, is that sometimes, we normally use the standard approach. Conventional approach. But in some cases, it's not very good for the patient, and typically for oncofertility patients, because at a certain point you're called, one of your colleagues oncologists says, look, I have a young lady, she needs chemotherapy, we don't have most of the time. They take 3 weeks to make a diagnosis and a treatment plan, but then they ask us to do on the spot, within 24 hours something. And then I think it's nice that you know that in the late follicular phase you can start, same number of oocytes, etc., etc. This study that we did was not powered for outcomes or pregnancy rates, but from other studies, we are not the only one doing this type of studies. We know that the live birth rate, the ongoing pregnancy rates are the same. So in other words, we have the choice, and basically in our center, the choice is made mainly, well, we run about 5,000 to 6,000 cycles a year, so we work every day of the week, 7 on 7, year on.
So there is no specific choice for the
No, we were interested to see, is this a valuable approach for maybe oncology patients, so the women that need to start very quickly. And there, I think there is a huge benefit.
But both the study you had showed that there is no difference, so you can.
We don't expect a difference, no.
But it is good for particularly one group of patients.
Yes, and maybe costs is also, of course, an important issue. You save on GnRH antagonists, so you can save on cost there, if you like, also.
Thank you, sir. Thank you. So it is a dream of every endocrinologist to get good. After all, if suppose onco patient is there, we want to give them a good pregnancy rate and live birth. Nowadays, people are using GnRH analogs during the luteal phase in addition to progesterone, either in single or multiple doses. Do you do the same practice, or what is your thought on that?
No, we don't do it. And again, the reason why we don't do it is not because it doesn't work. There is a nice abstract on ESHRE now from a French group, and they used, in fact, it was a randomized control trial where, in fact, they used either the luteal phase support by progesterone, either GnRH analogs. and they found that, in fact, GnRH analogs did a nice job.
Okay.
This is not new.
And this is very old. People are using it previously also.
There are quite a lot of studies, also well-powered prospective studies. There is even a meta-analysis on it showing that indeed it may be beneficial. The only problem is, of course, the cost. It's huge cost.
Because it is old wine in new bottle.
Yeah. So that's one thing. The cost is quite high, and also safety-wise, they're always referring to old data, and indeed, I remember 30 years ago in Brussels we started to use GnRH analogs to suppress patients, and typical suppression in the late luteal phase, and eventually some of the women that were under GnRH analogs, eventually they got pregnant spontaneously, because of course you have the corpus luteum rescue when you start using it, and they eventually got pregnant. And so later on, when they were under GnRH analogs, well, we stopped it, and then we looked to what happened with the newborns, and there are quite some case reports like that which they don't show any problem. But the truth is we don't have a large series with a good follow-up. So safety-wise, I'm not sure. So
not sure.
First of all, it works, maybe a little bit better even, but the problem is cost. Safety, question mark.
And we are not sure that there is no congenital malformation with this molecule. You had not seen, that is fortunate for our patients, but it may happen.
Yeah,
it may
happen. Never know.
Never know, sir. So, sir, nowadays we are programming every cycle pre-treatment with estradiol. It is now in frozen policy, in natural cycle IVF policy. So, if we give estradiol in luteal phase, does it improve the number of oocyte retrieved, particularly in women age group of 38 to 43, in which we have used antagonist protocol with corifoliatropin alpha?
Yeah. Again, there is an abstract here in ESHRE.
Yeah.
If I recall well, again a French group. Yes. And eventually in that group of women over 38, they tried to look whether indeed using the estradiol could help, and apparently they have seen in that group that they have one, if I recall well, one oocyte more.
Then it's more beneficial, because this age group we are not getting even though much oocytes.
In that age group, indeed, the number of oocytes may count, but again, in the end, of course, it's the live birth rate that we should be aware of, and that's still a question mark. But at least if you can get one oocyte more in that group, not bad at all.
Not better. So we can use in late
we can use it, and well, yes. Again, maybe it's not standard at the moment, but again,
we will have that more from Brussels group. We have got papers.
It's also useful, I think, when you know that if you're dealing with a poor responder and you do a standard protocol and still the number of oocytes is not sufficient. Always, we as doctors, we are trying to figure out what can we do to have maybe 1, 2 oocytes more. Well,
it's good.
Maybe a good option.
Sometimes jugglery can work.
Yeah, it's a good option to think of.
Now, sir, few questions regarding RPL, recurrent pregnancy loss. Still there is enigma, particularly when there is idiopathic, or maybe that because of allogenic immune response to paternal antigen. When we cannot justify a lady that why you have got abort, why your fetus is rejected. Your uterus is why is not compatible for this particular fetus. In this type of cohort of patient, is changing of gametes, particularly if you use ovum donation program, is it beneficial?
It is proven already in the 80s that it's beneficial in older women. But here the abstract that probably you're referring to is an abstract where they in fact try to figure out whether oocyte donation would be a solution for younger women. Who are dealing with pregnancy loss, early pregnancy loss. And the conclusion is it is not. And that is not surprising, I think, because we know that if you're young, aneuploidy, the embryo is most of the time only, let's say, 2 out of 3 embryos are euploid. So aneuploidy is not the cause, it's other things. Maybe indeed the progesterone is not high enough, maybe some other problems that we
cannot explain.
And that may, quite often we cannot explain. But at least what you expect from this study, what they found as a conclusion, is what we expect in younger ladies with recurrent miscarriage. Oocyte donation would not change a lot, and that's
but particularly it is helpful in older age group of patients.
In the older age group, yes, that's an old story. Yeah, if you're 40 plus,
then we can use
definitely oocyte donation can help you. Yes.
Let's continue same on RPL, sir. So we have got lots of discussion on microbiota and menstrual bloods. So we have seen that if we compare control with recurrent pregnancy loss and unexplained infertility, patient has got different menstrual blood immune profile, including altered natural killer cell subtype, which indicates altered cytotoxicity. Sir, what you find a difference in menstrual blood lymphocyte between control group of recurrent pregnancy loss and unexplained infertility? What is the difference in lymphocyte?
Well, basically, in fact, this is a new domain. The immunology of recurrent pregnancy loss, and there is not a lot known so far. It's all about the balance of two types of natural killer cells makes that you have implantation, that implantation is facilitated or does not take place and there is a rejection. Now, this study, it's a German study. In fact, they're looking whether indeed, for me, the abstract is nice because they did two things. And one of the things is they were looking whether if they can take out a natural killer cell of a sort of profile, immune profile from menstrual blood. Because typically what we are in Brussels, we are doing the same type of studies. And what we do is we take a biopsy, an endometrial biopsy. Yeah. And on that biopsy, we look to the immune profile.
Immune profiles or interleukins.
But here, the nice thing is that they looked whether indeed just trying to take the cells out of the menstrual blood, so the shedding of the endometrium, that they could correlate it, and apparently, indeed, the menstrual blood profile was comparable to the endometrial biopsy, which of course is much nicer. And then in the second part of that study, they were looking to the imbalance, and there again, they could see that in the menstrual blood, again, the imbalance, you need a certain type of natural killer cells to get implantation, otherwise you get, in fact, the loss. So no surprise there, but the nice thing was that they, and this is something we also try in Brussels, to try to get the immune profile from menstrual blood, and that's difficult. Technology-wise, it's difficult. So it's a very nice abstract. They have the technique now to isolate the right cells and to get the profile. So it will be nice, let's say, approach to do more studies and to get more knowledge about the immune profile, which is favorable for implantation and ongoing pregnancy rate.
So naturally we are again going with the nature. At this point,
the study has no clinical application, I would say.
It is just a theoretical.
It's a very, very theoretical, and it's a proof of concept of an approach.
So we can know that something is there that we can't control, or we can have things that this is the cause why you are having recurrent pregnancy loss, or why you are having unexplained infertility. So unexplained has got some explanation with lymphocyte theory.
With the imbalance, apparently,
Sir, how you are dealing with fibroid leiomyomas? Because there is always tug of war between the reproductive endocrinologist and laparoscopists. Whenever they see fibroid on ultrasound, they want to remove, and you people or me people are saying that medical treatment we are doing. Recently, we have got one very good treatment of relugolix 40 milligram with estradiol 1 milligram, and with our old friend norethisterone 0.5 in reducing uterine volume in leiomyoma. Do you use same type of treatment in your protocol?
No, it's just recently been introduced in my country. So it's a recent new drug. Which fortunately for us is reimbursed. But anyway, so we don't have a lot of experience with it. But the nice thing is that now, so far, what we were doing was looking, is there part of the myoma in the cavity, yes or no? And even then, if that was not the case, we were looking to the age. If somebody is 40 or 40 plus, we're not going to lose time by removing the myoma
and waiting for 2-3 months,
waiting, etc., and the surgery. And now we have a nice drug and it shows that there is a huge reduction in the volume of the myomas. So this opens up new opportunity to do studies, because maybe, even though the myomas are not really big, using this drug or not using this drug may have an impact on the result of IVF treatment.
So is there any long-term implications of this cocktail, that it will, afterwards it will increase the size of myoma?
Well, apparently more than a year, the size was still very, very reduced, which is good. So then afterwards, pre-treatment, and then, you can do a course of IVF trials, maybe with a better outcome than so far we don't know. We always go for surgery, GnRH analogs, but they didn't work very well. But this drug does a nice job.
So here
I'm awaiting not for the studies to see whether they reduce in volume, but what the impact would be for us in an IVF
specialist. Don't losing their time and use the cocktail.
Yes.
So cocktail has
more
also
patient friendly.
More patient friendly, and because we are doing all these three things, there is estradiol, there is progesterone, and there is
there is an advantage.
Thank you, sir. Yesterday we have got very good poor responder session. If you had heard that, and I had opportunity to listen the talk of Noah Early. She has done a multicentric randomized control trial on intra-ovarian injection of platelet-rich plasma in women with poor responder. And sir, naturally she had concluded that there is no difference in both groups. Do you do this type of things in your patient for ovarian rejuvenation?
Not yet. Let's say that we do have ongoing research in the immune environment of implantation, no implantation, etc., and all these things. But so far, the studies on the PRP, they are not controlled. They're dealing with very heterogeneous populations, either for thin endometrium or for poor ovarian response. So the both target groups, all the studies so far that we have, are so heterogeneous, not well controlled. Sometimes it's very strange, miraculous improvements. It's too good to be true.
But sir, one thing is good. One thing is there in India. We had made Ovarian Rejuvenation Society. Recently, we had made this type of society. They were particularly looking for this ovarian rejuvenation with PRP and
so hopefully, what you can do, multi-center, prospective, randomized control trial,
and we are also putting stem cells also.
Yeah, because the problem is that now everybody may start doing it, let's say in a non-prospective designed way, and then compare with historical data. And if nobody is doing the right study, well-controlled placebo control is impossible, but with the control group, prospective, multi-center maybe, then maybe 10 years from now we will still not know the answer whether it will work. So hopefully you in India, you have maybe the chance to do this, to show to the world very quickly it works or it doesn't work.
Thank you, sir. Thank you very much, sir. Sir, now same on thin endometrium. You agree with me that adequate functional endometrium with very good progestinization, 3 lines gone, good anchoring alpha B beta 3 integrins, fabulous pinopores, these are the primary good outcome for pregnancy conducive endometrium. But once you see there is very thin endometrium, do you use PRGF? That it is growth factor?
Again, not yet at the moment.
Not yet at the moment.
In my country, there are people doing, and those who are doing it, the most popular approach is the subendometrial by hysteroscopy, so injection.
Injections.
Yeah, that's the most popular. But again, there are techniques where they just instill it. There are techniques where they do it subendometrial. And again, here also on this meeting, there is an abstract.
Yeah.
3 different groups, 2 approaches. So again,
multiple puncture, 4 puncture, 0.5 ml, 0.2 ml.
It's a non-controlled study. It's not prospective. It will the conclusions for me.
But what you use in thin endometrium? So thin endometrium is very big challenge for our IVF patients.
Yeah. Well, typically we will improve, let's say, the luteal support. We will give additional estradiol, intravaginal, sometimes even PDE5 inhibitors.
Okay. So again, using the cocktail. Ultimately, medical cocktail.
Yeah. But it's true, in some patients, the thin endometrium remains
thin. But even though, sir, we had seen that even in thin 3 to 5 mm pregnancy
occur. But of course, with lower success rates. But they occur, yes, sure.
So there is a notion, sir, nowadays people are shifting from mono to dual trigger in HCG and GnRH antagonist. Have you judged a notion between if you give dual trigger, then we will get good quality eggs for ESHRE? Is there any benefit of giving dual trigger and freeze them all?
Well, we did a study, and the short answer is not really. No, the idea is indeed that you get more eggs, because in some studies you get more eggs, but in our study we didn't get more eggs. And then getting more eggs is one thing, but the question is, will you get more babies born? And at this point, I think that we have to say no, probably not. It's our standard treatment at this point in Brussels. But
that is the dual trigger.
The dual trigger, but we are already discussing for a while whether we should not stop doing it, because again, it's the cost is a little bit higher.
Yesterday we have got also one paper that they are doing dual stimulation. One stimulation finished, then again second stimulation, then they will get 2-3 eggs more. So it is, you are doing this?
We have done a study, but probably not the right protocol, because in our hands we didn't have more oocytes. But yesterday was also one of our former colleagues, Annalisa Racca. She presented a nice randomized controlled trial in which she shows that indeed she had more oocytes.
At least three more oocytes they are getting with a single cycle and 2 pickups.
So for us in Brussels, we have to rethink our protocol because we were not doing it the right way.
Thank you very much, sir. Now don't forget our 50% male patient, because ultimately they are also responsible for infertility. And yesterday there are 3 very good talks on freeze all by Dr. Laura, Joan and Angeline in a company symposium, and they said there is a cow that we have to do all freeze all. Is there freeze all policy will give any more benefit to our male factor infertility patients, particularly if you want to do the frozen cycle?
Well, in the paper that you're alluding to, yes, but I've some thoughts about the way it's a retrospective effect study on a lot of cycles, more than 20,000 cycles, if I recall well. But basically there are a lot of confounders in that study, because the freeze-all are day 5 embryos, and the fresh that they did in that were day 3.
Day 3 embryos.
And then of course, obviously, there is an added value, of course, of freezing day 5, and the success rate are known to be higher. So obviously, what you can expect is that the cumulative pregnancy rate also in our male patients by using frozen embryo transfers is something that is beneficial. But I think
for the patient,
that's what you're
so future will be freeze all, or future will be
we do
fresh or frozen?
Well, basically I think there are lots of studies that show that freeze all versus the standard fresh transfer whenever possible doesn't show a difference. But the way we do it in Brussels, we do quite a lot of freeze all. 40% of the cycles is freeze all, which is quite a lot. But what you need is, I think, the right indication. And the right indication may be that there is a progesterone rise, that there is a risk for hyperstimulation, that there is a thin endometrium. Things like that, I think,
freeze-all policy.
Think about freeze-all. But the second thing you need is a good freezing protocol. And vitrification still needs golden hands. In our setting, we have 30 lab technicians. Not all of them can do vitrification. Because but you need to follow a good protocol, and you need, well, really experienced hands to make it work perfectly. So if you don't have a good vitrification protocol, then I would not promote freeze-all too much.
But sir, you are master of vitrification because you have started your thesis on vitrification in 1986. So you are
in mouse.
So everything is coming from the mouse or from the guinea pigs to the
human.
But
in those days we thought it was too toxic, so we didn't dare to do it in the human.
But thank you very much, sir. It's indeed pleasure to have a conversation with you. I expect that our audience will get very good message from this our talk, and always bless with your turmoil of knowledge as a Tournaye, Herman, man of her, army of her. So thank you very much, sir. Thank you. Namaskar, sir. Namaskar.
Pleasure was mine.
Thank you, sir. Thank you very much.